Hi, my name is Lisa, and I'm doing my case study on internal carotid artery stenosis. For my patient's history, he did have a post-left carotid endarterectomy in October, and an endarterectomy is a surgical procedure to remove the plaque from an artery. His vitals were 148/61, oxygen was 97%, his heart rate was 49, and his weight was 73 kilograms. He did have a history of hypertension and is on lisinopril. When he came in for the procedure, he had no presenting symptoms. The imaging findings were severe stenosis of the left bulb and proximal internal carotid artery. Carotid stenosis, also known as carotid artery disease, is a narrowing of a carotid artery. The narrowing is caused by plaque or fatty deposits along the intima layer of the artery wall, resulting in reduced blood flow to the brain and, in some cases, a complete blockage of the artery. Carotid disease occurs when lipoproteins accumulate in the intima layer of the artery and is modified by oxygen. When this occurs, cytokine release leads to monocyte deposits in the artery wall. These monocytes then transform into foam cells, causing smooth muscle cells to migrate to the intima and form a lipid-laden plaque with a fibrous cap. The degree of stenosis is determined at grayscale, and Doppler ultrasound should be classified into categories of normal, so no stenosis, less than 50% stenosis, 50 to 69% stenosis, or greater than or equal to 70% stenosis, which would be severe. Internal carotid artery should be diagnosed as normal with an ICA peak systolic volume is less than 125 centimeters per second, and no plaque or intimal thickening is visible. This patient's peak systolic volume was 482 centimeters per second, so it was definitely classified as severe. Risk factors include smoking, obesity, elevated cholesterol levels, older age, diabetes, family or personal history of coronary artery disease, high blood pressure, and being inactive or a sedentary in lifestyle. Atherosclerosis is the most common etiology for stenosis, which is the hardening of arteries due to plaque buildup. Because the carotid arteries deliver blood to the brain, carotid artery disease can have serious implications by reducing the flow of oxygen to the brain. The brain needs a constant supply of oxygen in order to function. Even a brief interruption in blood supply can cause problems. Brain cells begin to die just after a few minutes without blood or oxygen, and the narrowing of a carotid artery becomes severe enough to block blood flow and obstructs flow to the brain, a stroke may occur. There are different options for treatment that include, if a patient's artery blockage is less than 50%, the risk of surgery or stenting may outweigh the benefits. The physician may treat the blockage with anticoagulant medications such as aspirin, which will prevent clots from forming. The physician also may prescribe lifestyle modifications, including stopping smoking and reducing dietary cholesterol, as well as the use of cholesterol-lowering medications. With blockages greater than 50%, surgery may be the best option. Patients who have had a TIA may also be candidates for surgery. The first option for surgery involves making an incision in the neck and microsurgically removing the plaque within the artery. There is a risk of a stroke during this procedure, although that risk is to be very small. The second surgical option is angioplasty and stenting, which is a minimally invasive procedure that does not require an incision in the neck. A catheter is inserted through a small pinhole in an artery in the groin. The artery is expanded with a balloon, and the stent is put into place to hold the artery open and keep the plaque against the arterial wall. The minimally invasive stent procedure is used in a select group of patients who meet the criteria. Studies suggest that 5% of individuals with carotid artery stenosis of 70% or more will have a stroke within 5 years. Typically, a lifestyle change needs to happen to help the narrowing from progressing. Things like a healthier diet and cholesterol medication will aid in decreasing more plaque buildup. Here you can see a still image of the stenosis in the left bifurcate of the common carotid. The narrowing shows up more white in the middle of the black vessel. At this point is where the left common carotid splits into the internal and external carotid arteries. You can see the internal jugular vein sitting superior to the internal carotid artery. This slide shows a split screen with color Doppler on the right. If you look at the top of the internal carotid artery, you will see yellow in color, which indicates more turbulent flow. If the flow was normal here, it would show as red. This shows you the color flow with pulsed wave Doppler as well. The marker was placed right on top where the turbulent flow was occurring on the proximal internal carotid artery. They acquired the value of 482 centimeters per second here, which is what is used to determine the severity of the stenosis. In the chart, you can see that if the peak systolic volume is over 230 centimeters per second, it is classified as severe. You can also see that the patient's end diastolic volume was 176 centimeters per second, which goes over the 100 centimeters per second mark for severe as well. These two values mean that the plaque buildup is greater than 50%. Here I wanted to show a reel of the color flow through the narrowing. For the differential diagnoses, I've listed aortic stenosis, atrial fibrillation with cardioembolic event, seizures, ischemic or hemorrhagic stroke, and complex migraine headaches. A duplex ultrasound, like the one I've shown you, and a CT angiogram are the top two procedures to help visualize the plaque within the arteries. It is possible for the stenosis to come back if no lifestyle changes were made. A person may undergo more than one endarterectomy if the plaque returns. Another possibility is that the stent could be misplaced or a patient develops in-stent restenosis, which is corrected through another surgery. Here you can see pictures of an N block where they remove both the plaque and the stent altogether. This was not from my patient, but one that I found online, so I wanted to show a picture of it. And here are all of my references.